Welcome viewers to part 4 of Fabry disease explained. Hello Fabrienne. How are you doing today? Having a bad day? Will you manage for 16 minutes? That's good. So, this video will be a bit different from the previous ones, as this one isn't about the accepted state of knowledge regarding Fabry disease. Today we will be covering a current discussion. This discussion is of direct consequence for Fabrienne, and it presents the actual reason she wanted to make these videos. That's why a strictly neutral perspective is not her aim. Still, we try to present all the relevant data from both sides, so you can make your own opinion. As the subtitle of this video suggests, we will be discussing some specific mutations. So, we'll start by diving into Fabrienne's DNA to discover what mutations she has. We'll take the same drop of blood we examined in our last video. Now, about here should be that same white blood cell. Cutting it in half again, we see the nucleus, and inside are those X chromosomes, one of which carries a mutation. Now, if we compare the DNA of the affected GLA gene to the reference sequence, we see that exon 1 is fine, and so is exon 2. Only in exon 6 we find a mutation. At position 937, a G is exchanged for a T. This leads to an amino acid change in position 313, where an aspartic acid is exchanged for a tyrosine. Further explanations on how this genetic code works will be provided in a separate video. One word about the terms used. Geneticists use the term variant for any deviation from the reference sequence, mutation for the ones that are damaging for one's health, and polymorphism for the harmless ones. As mutation is likely to be the more familiar term for most viewers, we will mostly stick to this one. Fabrienne's mutation is abbreviated as D313Y. Some scientists and physicians consider this mutation and several others to be benign or neutral, of no clinical significance. Others maintain that these variants do cause, at least in a number of patients, some form of Fabry disease. As Fabrienne is obviously unwell, it should be clear which side she picks. For a start, let's try to find out why some consider this variant to be benign. The rumor started in 2003 when a team from the Mount Sinai School of Medicine in Manhattan, New York, in cooperation with a French team, ran some laboratory tests on the mutated enzyme. They found that, while this mutation is bad for the enzyme, it's not as bad as the other mutations that were included in this research project. Additionally, out of over 1 million affected people in the US, they presented one healthy person with this mutation. From France. The logic is, of course, either all have symptoms or none have. This is true for some genetic diseases. For others, only a number of affected people develop symptoms. This phenomenon is called penetrance. An example for a disease with very low penetrance is acute intermittent porphyria. Only around 1% of individuals with certain mutations on one of their HMBS genes develops symptoms of porphyria. Aren't some of the authors' names familiar? That means someone who participated in the 2003 research must know by now that one basic assumption was flawed. Any corrections? Not that we know of. The conclusion from the 2003 research was that the D313Y mutation does not cause Fabry disease in any and all of the affected people. Now, if someone draws such a far-reaching conclusion based on so little data, if that conclusion proves correct, it's genius. If that conclusion is incorrect, well, it's not genius. Next, we have a paper from 2012. This paper includes 2 patients. The 20-year-old daughter had unspecific pain in her arms, which might be caused by her GLA variant, but according to the authors, no Fabry disease. At least not yet. Her 53-year-old father, apart from being a heavy smoker, was healthy. You might think, for the numbers involved, That's still a little meager, but it's twice the patients that were examined in 2003. And this time we have actual clinical data. Like, for example, this phrase about enzymatic activity below the norm. That shows the gap between the laboratory settings of the 2003 experiments and what happens in actual people. In the conclusion it says that some variants might cause a continuum of clinical presentations. There it is. That's exactly what we see in the families of Fabrien's friends, at least for the D313Y mutation and for the A143T mutation as well. And we never heard anything of this again. Then, in 2013, we have a paper regarding white matter lesions and the D313Y variant. White matter lesions are a kind of mild brain damage that shows up as white spots on an MRI. All 7 D313Y patients included in this study had them, and the 2 family members without the mutation didn't. White matter lesions aren't as bad as acute renal failure, and almost all old people have them, but they're not nothing either. So, is the D313Y variant maybe less neutral than some had expected? We cannot change the symptoms caused by genetic mutations, but we can change how we call them. Do you remember that long list of possible Fabry symptoms from the first video? In 2014, a Dutch team presented a paper redefining what Fabry disease is. They divided the Fabry symptoms into specific and unspecific symptoms. An example for an unspecific symptom is stroke. There are numerous risk factors for stroke, but usually not one single cause. When a person suffers a stroke, it's impossible to tell which risk factor contributed how much to that stroke event. In contrast, specific symptoms have few possible causes, and the exact cause can be determined. The Dutch team examined all possible Fabry symptoms and found that there are 3 specific symptoms for Fabry disease, and all the other ones are unspecific. Now, if an individual has an unspecific symptom, quote, this symptom could be completely unrelated to the detected GLA variant or could be caused by a non-classical form of FD, end quote. In practice, this means that, quote, difficult clinical dilemmas have emerged as these individuals may be misdiagnosed as having FD and treated with costly ERT, end quote. Meaning the diagnosis of Fabry disease might also be correct, but a misdiagnosis is theoretically still possible. For those individuals, this paper suggests that treatment should be avoided. The reason for this are the costs, not possible adverse effects for the patients. If the costs are a problem, then the costs must be reduced, not the number of candidates for treatment. The authors, however, act as if the cost of a therapy is a scientific constant, like the speed of light in a vacuum or the ratio of the circumference of a circle to its diameter. And therefore, in case of doubt, they must find it preferable to treat patients with psychoactive drugs, even if they actually have Fabry disease, because that's the consequence of this piece of science. Thus, the authors not only define classical Fabry disease with at least one specific symptom, and non-classical Fabry disease with only unspecific symptoms. In addition to that, a few mutations are explicitly mentioned as benign or possibly benign. Now it's official. The D313Y variant doesn't cause Fabry disease based on one lucky woman. Now, this weren't a problem in itself. Botanists took the word berry and applied it to chilies and bananas, while strawberries and chokeberries are berries no more. However, botanists then invented new words to describe strawberries and chokeberries. They didn't pretend like they don't exist. It's different with this new, narrow definition of Fabry disease. It creates a blind spot, where many people affected by GLA variants do not meet this narrow definition. In effect, a treatment of the cause of their problems is refused, leaving only a far less effective symptomatic treatment, and that is a problem. We see the result of this confusing new situation in a paper from 2015. This is a review of Fabry mutations amongst Portuguese stroke patients, and thus it's exclusively about an unspecific symptom. The paper is mainly about the GLA variant R118C, but the D313Y mutation is also mentioned as follows. Remarkably, the frequency of the GLA variant D313Y, which has been characterized as a non-pathogenic allele, was significantly higher among male stroke patients than in controls. The conclusion about the R118C variant is, overall, those data strongly suggest that the GLA variant R118C does not segregate with FD clinical phenotypes in a Mendelian fashion, but might be a modulator of the multifactorial risk of cerebrovascular disease. Thus, this variant does not meet the narrow definition of Fabry disease, but it does increase stroke risk. Still, this paper is used as a reference to prove the non-pathogenic nature of this variant. And there we have the blind spot. There are still some rebels who continue to call it Fabry disease. Even last year a paper was published reviewing the available literature to date. And guess what? Specific symptoms like cornea verticillata and angiokeratoma are far less common amongst D313Y patients than neurological problems, which also means some D313Y patients do have specific Fabry symptoms. Variants like D313Y and A143T challenge our understanding of what Fabry disease is. The severity of symptoms varies greatly, even in single families, and women appear to be more severely affected than men. This contradicts some long-standing assumptions. Studying these variants might lead to a better understanding of genetic diseases in general. Ignoring them will certainly lead nowhere. Fabry disease in D313Y patients is described more than once in scientific literature, and that means that it's clear where Fabrienne's symptoms come from. At this point, I would like to read a statement from Fabrienne in her own words. Should there be any physicians watching this, please don't ignore us. There are many of us, and we are often misdiagnosed. We receive treatment for fibromyalgia or dysautonomia, and sometimes even psychoactive drugs. The success of those treatments is limited, as many of us are still struggling with the simplest tasks of everyday life. Some are bedridden with pain and exhaustion. The lucky few who receive treatment give us, the untreated majority, a sliver of hope. Fabry disease is still so poorly understood that 20-year-old conclusions have to be questioned, especially predictions that don't hold up in reality. So please look at the people in front of you. We are suffering and we need help. We have no other option. All in all, we feel safe to state D313Y, A143T, and likely several other variants cause a continuum of clinical presentations. Common symptoms include pain, fatigue, gastrointestinal problems and brain fog. The most severe cases are neither late onset nor mild, amounting to severe disability. Fabry-specific treatment greatly helps these patients, especially chaperone therapy. Diagnostic laboratories often don't report these variants anymore, even if unambiguously identified by gene sequencing. Fabry-specific treatment of these patients is commonly refused, even if reported by diagnostic laboratories. So, if we can't get diagnosed and we can't get treated, what can we do? First of all, we are dealing with a risk factor for stroke, and in case of stroke, time matters. That's why we should learn to recognize one quickly. So for you and your loved ones, here's the fast test with Fabrienne. The first part is facial weakness. Can the person smile, or does the eye and mouth droop in one half of the face? Next, the arm test. Ask the person to raise both arms. Thirdly, we check for speech problems. Ask the person to repeat a simple phrase, anything that comes to mind. If a person cannot perform any one of these tests in their usual fashion, it's a reason to call your local emergency telephone number. What else can we do? That's right, we pray. Any further suggestions? We keep our spirits up. That's it for today. Thanks a lot, Fabienne. You did great again. There are some videos in the works that dive into the details of Fabry disease a bit further, discussing topics like intronic mutations, the genetic code and sphingolipids. Keep an eye out for those. Apart from that, thanks a lot for watching. Feel free to write and have a wonderful day. Thank you.